Welcome everyone, and thank you for joining us. We'll be starting in just a couple more minutes. All right, good afternoon. My name is Annie Montz. I am the program coordinator for the Fairbanks Center for Medical Ethics, and welcome to the November Fairbanks lecture. Thank you for joining us remotely. We mentioned last month that we will be hosting our biennial ethics conference on February 12th of next year. This is going to be a virtual conference, and we plan to open registration in the next few weeks. If you are already receiving emails for our ethics lectures, you will receive an email when registration opens. We're really looking forward to having everyone join us virtually next year for that. A few preliminaries for the lecture. Nothing really has changed. We're all still doing technology and it's working better most of the time, I think. So please, we appreciate your understanding for any issues that we may have during the webinar today. It is being recorded. It will be available on our website, fairbankscenter.org, within the next few days. The recording is eligible for continuing education credits and continuing medical education credits for 30 days. And we encourage you to send the video along to your colleagues so they can watch it as well. You will receive a link for the evaluation tomorrow at the email address you used to register for this webinar. If you need the CME and CE credit, you need to complete that evaluation in order to get the credit. We strongly encourage the rest of you also to fill it out, even if you do not need the credit. This allows us to not only track virtual attendance, but also allows you to provide feedback and comments on the lecture. The question and answer box is available to post questions. We will not be responding to most of those questions until the end of the presentation when Dr. Halverson is ready. And Dr. Halverson has no relevant financial conflicts of interest to disclose. So it is my privilege to introduce Dr. Colin Halverson today. He joined the Indiana University as an assistant professor of medicine at the School of Medicine, a faculty investigator in the Center for Bioethics, and as a research scientist at Regenstrief Institute last year. And this year he was appointed an adjunct assistant professor in anthropology. He holds a Ph.D. from the University of Chicago in medical and linguistic anthropology and completed a postdoctoral fellowship in bioethics at Vanderbilt University. His research focuses on ethical issues related to genetic testing and the return of results, in particular with regards to cancers and rare diseases. Outside of work, Colin enjoys painting, baking, and caring for his numerous plants. The beautiful one looks like right behind him as well right now. So thank you for being with us today, Dr. Halverson.
Thank you for having me. All right, I'm happy to be here. I'm going to move on from this slide. I was shadowing in medical genetics at a hospital far from Indiana University. Sitting in the workroom, our upcoming patient was already being described by the clinicians in the room as difficult. One of the genetic counselors called the patient and her family crazy, noting that they were vegans. She believed that the patient might just be suffering from malnutrition, not hypermobile Ehlers-Danlos syndrome, or hEDS, as the patient herself suspected. As we walked to the room where the patient was waiting, the geneticist joked to me quietly, not to be overheard. All of my patients have Ehlers-Danlos. It's too diffuse of a diagnosis to take seriously anymore, he opined. We actually ended up seeing two patients in that room. A mom, we'll call her Caroline, and her 11-year-old daughter, we'll call her Jess. We spent nearly 2 hours with them in that room. Both patients were thin, deeply tanned, and flexible. When we sat down, Caroline was seated with one leg wrapped like a vine around the other. At another point, she had both her legs on the chair, tucked up to her chest, her sweatshirt pulled over them. She stayed sitting like that for quite a while. The daughter, Jess, was, quote, a performer, the geneticist noted aloud, eager for attention and having a bit of a hard time sitting still. She also spent a lot of time twisting body parts around other body parts while the geneticist and her mother tried not to pay attention to her. Caroline was talkative. She spoke about veganism making their tissues thinner and purer, but mainly she focused on a variety of health issues she'd been experiencing for several years. Both patients were under suspicion for hypermobile Ehlers-Danlos syndrome. Caroline had had numerous health problems related to loose joints and tendons, a slipped uterus. Luckily, it didn't rupture, as people with other forms of EDS often experience, sometimes leading to death. Half a dozen knee surgeries, shoulder issues, etc. The geneticist asked whether Caroline knew just how many surgeries she'd actually undergone. The woman got somewhat defensive. Of course I know. The geneticist had the mother do the usual hypermobility tests, touch her thumb to her arm, dislocate her fingers, shoulder, twist her feet in all different directions, touch her toes, etc. Her daughter did these things alongside her, and Caroline scolded her for being a distraction. When it did come to Jess's turn, the geneticist was much briefer. Caroline said her daughter had started getting confused really easily. This is not my daughter, she bemoaned. Jess had started not wanting to go for runs anymore, forgetting homework assignments and the names of distant relatives. Caroline listed off all the specialists she'd taken Jess to at multiple different hospitals, and one of these doctors had diagnosed Jess with fibromyalgia, but the mother was convinced that it was, quote, more than that. The geneticist consulted the medical history and noted that Jess had suffered a concussion a couple years earlier, but her mother said a neurologist had said the concussion had completely healed, so she thought the issue must be something else. Despite the somewhat tense atmosphere, the geneticist maintained a diagnosis of hEDS for Caroline, but said her daughter should merely be diagnosed with hypermobile spectrum disorder, which actually startled the child. Jess even teared up. She had clearly already grown pretty attached to the Ehlers-Danlos diagnosis. Maybe as a tie to her mother or her family in general, Caroline was convinced one of her older sisters also had the disorder, maybe as some sort of party trick, but not, it didn't appear to me, as a sick role. That is, not as something that separated her from the other social responsibilities or connections in her life. The geneticist recommended behavioral and physical therapy for Jess. The mother complained that she'd already had to borrow $4,000 from a friend to pay for PT for herself. The geneticist said that beyond that referral, there wasn't anything else he could do. Afterwards, Caroline told me that she thought the geneticist had not believed her daughter, but she said she, quote, appreciated and respected his honesty when he told her there was nothing else he could do. Caroline was upset about the lack of a diagnosis, though, and the referrals, which she considered insufficient. She said she cried on the drive home after seeing this geneticist. So as I'm sure you've already gathered, today I'm going to be talking to you about hypermobile Ehlers-Danlos, the experiences of patients with this disorder and the attempts they go through to get a diagnosis. I'm particularly interested in the difficulties this diagnosis causes for the doctor-patient relationship, not just in terms of the symptoms and their management, but also the psychosocial issues and dynamics that it entails, as well as the mutual distrust that it engenders. I'm going to describe several of these cases and try to develop general odyssey that these patients undergo. And I hope to demonstrate that there are direct negative iatrogenic consequences to this long drawn out process. I'm also really interested in how patient suffering is validated, both by clinicians and other members of their social world, and the power of diagnosis for a patient's social identity. And as was already mentioned, I have no conflicts of interest to disclose. So what is hEDS? Hypermobile Ehlers-Danlos syndrome is a hereditary connective tissue disorder. It's a part of a spectrum of disorders. Other prominent forms include vascular and classical Ehlers-Danlos. Unlike these other two forms, though, hEDS lacks a known genetic component. So the other two you can actually run a genetic test for. hEDS you cannot. There is, however, currently a large study based here actually at IU that's currently searching for a contributory genotype for hEDS. The primary symptoms of this disorder are joint hypermobility, chronic pain, and fatigue, often with multi-system involvement. And there are also psychiatric comorbidities which complicate the picture. Many experts consider it to be a rare disease with an incidence rate of around 1 in 5,000. But many of the patients I speak with believe that it's much more common than is currently recognized. And this is primarily due to the fact that patients oftentimes have a different set of criteria that they consider relevant to the diagnosis. I think it's also worth noting here that 95% of those people diagnosed with Ehlers-Danlos, hypermobile Ehlers-Danlos, are females. Genetically, there's no reason that it would have this gender segregation, but physiologically, I think it's interesting that one of the theories I hear raised is that males have greater muscle mass around their joints, and so this acts as a sort of rescue from the otherwise disabling symptoms that the female patients experience. I would also be remiss as an anthropologist not to say that there doesn't seem to be something cultural about this as well. Why Ehlers-Danlos is as a diagnosis is applied more frequently to women than to men, including why men are not as likely to seek diagnostic assistance for these often reduced types of symptoms. Ehlers-Danlos, hypermobile Ehlers-Danlos is notoriously difficult to diagnose for a number of reasons. The first of which is that it relies heavily on a self-report of pain and psychological distress. That is not to say at all that there aren't objective metrics used as well, validated scales used for measuring hypermobility, for instance. There's also the issue of criterion overlap. So the symptoms experienced by patients with hEDS that are used as differential are actually common in a number of other disorders. Sorry, I'm moving out of the sun a little bit. I'll probably have to do that again. So there's a significant overlap of symptoms with a number of other syndromes, including chronic fatigue, benign joint hypermobility, Marfan syndrome, and osteogenesis imperfecta. Finally, the criteria used to diagnose hypermobile Ehlers-Danlos have changed repeatedly in the past as well as recently. So it's not just that patients have a different set of criteria that they sometimes apply for determining whether or not an individual should have this diagnosis. It's also the case that depending on when a geneticist or other specialist was trained, that they might accidentally be using no longer recommended criteria. And also, as I mentioned, with the search for a genetic cause, it's possible and actually likely that the criteria will change again in the future, and possibly even the near future. This is my first time talking about this project publicly, so thank you for being with me at this stage in my journey. I've just completed the first draft of the first paper of a pilot study, which consisted of 21 interviews, and this is what today's talk is going to be based off of. 19 of these individuals had a personal diagnosis, meaning a clinical diagnosis for themselves of hEDS. And then I additionally talked to 2 parents of underage children who had had clinical diagnosis. And I did that simply for IRB reasons, to avoid speaking to underage patients. It's important to look, I think, at how long these interviews were. So I'm using narrative medicine and illness narrative techniques in doing these interviews, which really gives me an intimate view of the daily experiences and thought processes of patients with hEDS. And I hope this comes through in the talk today. One of my real goals is for the audience to have a chance to glimpse some of this intimate detail. And I hope and kind of ask that the audience takes this time to do your best to step into the shoes of these patients, not just to see these as a set of data, but to try to imagine what the subjective experience of this chronic condition is, both in terms of the physical and the social symptoms that it entails. So now moving to the results, demographics. Mainly I put this up here just so you can see, probably unsurprising after the previous slide, the enormous preponderance of female interviewees. Some more demographics. These I asked about these demographics for the purpose of getting evidence for a number of hypotheses I had about how hEDS might affect and be affected by other aspects of a patient's life. And I'll note here that when I say unemployed below, what I mean specifically is patients who don't have a job. And I'm including in that patients who sought a disability, but then were denied it. So this doesn't just include individuals who are currently seeking jobs. Many of these people are not, because they feel themselves to be too disabled to actually be able to hold down a job. All right, so you've already seen this phrase before, the Diagnostic Odyssey. I first encountered this term when I was interning in bioethics at Mayo Clinic. It's common enough in the rare disease community, but I am guessing that for many of you, this might not be a familiar term. What it refers to is this very long, drawn out process, often arduous experience that patients with undiagnosed rare diseases have to go through in pursuit of a diagnosis. And as someone with a background in social sciences and humanities, I was really struck by the literary quality of this term, which is so embedded in medical and scientific world. And so when I started going to analyze the data from my interviews, I was drawn immediately to a narrative style of analysis, and I playfully tried to compare the general narrative that was emerging from my perspective to Joseph Campbell's hero's journey from his book Hero of a Thousand Faces, which is common enough in my world. And I found it actually to be fairly useful in structuring narrated chronology. This is not as familiar for a lot of people outside of, say, anthropology. It's also been called the monomyth. It's a unified template for comparison of quest or odyssey type narratives that's been developed comparing across cultures, across the world, across history. It's been used as a tool to analyze everything from the Bible to Star Wars. But to my knowledge, it has not been used in bioethics. And so I'll be using this kind of as a touchstone throughout the rest of the talk. Not so much because I think it actually tells us anything underlying about how the world works, but because I think it helps us understand how individuals narrate their experiences of the world. I also want to say at this stage that of the 21 individuals I interviewed, only 2 of my interviewees received a diagnosis that satisfied them without undergoing the sometimes harrowing process of a diagnostic odyssey. Both of these individuals received diagnoses at very young ages, though one of them still did not completely avoid years of doubt and uncertainty related to his diagnosis, or her diagnosis, sorry. And the diagnosis did not, just getting a diagnosis does not stop chronic pain or its comorbidities for anyone, no matter how long or short the diagnostic odyssey. This is a chronic condition. And so now I want to go into the diagnostic odyssey and see what it looks like from the inside for someone with these symptoms to pursue a diagnosis and eventually get an hEDS diagnosis. So the first moment in this chronology is the always already step. I guess before I even get into this, I do want to underscore that there is no truly general hEDS patient, as I think will become like readily clear as we move forward. And so there's also no truly general diagnostic odyssey course for any of these patients. What I'm presenting is really a very broad perspective on the themes that continue to come up in the interviews for many, most, or oftentimes all of these patients. I've put up a number of quotes on the following slides. I'm not going to read them myself. I leave them to you to read at your leisure. I'm hoping that you do, like I said before, take this as an opportunity to get into the mindset and experiences of these patients. So the always already moment is a retrospective moment in the chronology of the Diagnostic Odyssey. And what I mean by that is that this is explicitly a reinterpretation of past events by the interviewees. These are moments from early childhood before the patient realized that there was anything more to their symptoms than they could handle without help. And so these things didn't even appear as concerning issues to the patients at this stage. This includes things like how one patient held a pen while she was in elementary school, being particularly good at gymnastics and other sports because the individual was very flexible, or an idiosyncratic but comfortable way of sitting. And so this was all before the trigger moment. This is the moment that drives the patient to commit to their odyssey. They leave their old, understandable life behind, and they're forced into a world of sometimes terrifying, overwhelming mystery and uncertainty. And so this is when those previous symptoms from the last slide finally become more than the patient can actually handle without help. This is the first time they move from a world where they feel comfortable, even if things are a little bit difficult for them, and realize that their experience is different from others. The plurality of the individuals I spoke to described their trigger moment as a form of head trauma, which I thought was interesting. But there were a number of other issues that led patients down this path as well. And these included car accidents, a near drowning, social isolation, and the death of a loved one. And this sets a patient on the path of the Diagnostic Odyssey. And going back to Campbell's discussion, he calls this the road of trials. For patients who end up with an hEDS diagnosis, this trial has many dimensions. The most immediate are the increasing and increasingly unmanageable symptoms that they experience. Most prominently, this is chronic pain and fatigue, but also includes for many, if not most of the individuals I spoke with, cognitive fogs, dysautonomia, fainting, headaches, rashes, stiffness, stridor, and vomiting. These become a part of almost daily life. This, unsurprisingly, leads to a number of secondary effects. The patients end up changing their life their daily life in significant ways. This isn't just in the day-to-day. These decisions have ramifications for the long term as well. So it includes things like dropping out of high school or college, changing career goals to be something that they believe would be more manageable or practicable based on the symptoms, and abandoning beloved hobbies and athletic pursuits. It's particularly the third of these three things that leads to the next stage in this road of trials, the psychosocial sequelae. Because of the subjective nature of pain, the experience of hEDS is primarily that of an invisible illness. Because others can't experience the pain themselves or see it experienced, this can lead others to doubt the actual severity or even existence of the patient's symptoms. So this has a clear limiting effect on the social lives of these individuals. It also has a limitation on the physical ability of these patients to join in on social activities. And these two things coupled can lead to extreme feelings of isolation and loneliness, which unsurprisingly can grow into depression and anxiety, on top of the anxiety that naturally arises directly from chronic pain. As the symptoms worsen, the patient eventually begins to interface more frequently with the medical system. While this may be helpful in some instances, it adds a new dimension of potential psychosocial distress. And I'm going to talk about all the different reasons for that in the following slides. The first of those is it's a rare disease. The majority of clinicians aren't going to be particularly familiar with it if they know anything about it at all. So a lot of the patients I spoke with actually have no grudges on primary care physicians for not understanding what it is, but it does nonetheless mean that these patients are not getting treated in a way appropriate to the diagnosis, and at the very least aren't getting the referrals that they could benefit from. Because of this lack of understanding, patients encounter a number of alternative diagnoses on this road of trials. Initially, these may feel like preliminary victories, but for many patients, these initial diagnoses run up against a wall at some point where they no longer are able to explain all of the symptoms or the most pressing symptoms that the patient is experiencing. And so the very long list that I put up on the screen here is only a part of the list that I actually have compiled so far. These are sometimes overlapping diagnoses. These are sometimes diagnoses that other individuals still think are relevant to their medical state. But the ones that I've listed here are only those that certain patients believed are no longer applicable or have been supplanted by an hEDS diagnosis. The lack of these diagnoses for explaining or diminishing the patient's concern about their health can lead to doubt on both sides of the doctor-patient interactions. Again, because of the subjective nature of many of the symptoms, clinicians can frequently doubt the patient is acting as an honest historian. From the first quote up here, you can clearly see that this form of clinical doubt can have clear negative psychosocial impact on the patients, but it also has negative medical effects. Patients may actually stop seeking help from Western medicine if all they feel they get out of it is doubt and aggression. And also this can lead them to have completely unmanaged symptoms. This also turns the corner and can lead to self-doubt. The patient may not have anyone in their lives affirming their symptoms and their suffering. And this can lead them to wonder whether they themselves are exaggerating or maybe even faking. All of the patients I spoke with did stop having this feeling at some point as the symptoms persisted, as they tried a number of therapies, including, again, the plurality of patients going and seeking mental health therapy as well. And yet the symptoms persist. Without the help of the medical institution in providing a diagnosis, many patients turn to other sources to conduct their own research and to get support. Most people turn to the internet at this stage. And this is really a diverse set of experiences. There are certain sites, including Ehlers-Danlos Society, that are run by specialists. Experts are constantly monitored by clinicians with relevant expertise. But there are also plenty of other places online that patients turn to, including Facebook, local support groups, etc. During this phase of the road of trials, patients may come to identify with the Ehlers-Danlos diagnosis before they even have a clinical diagnosis. For many people, it's online that they first hear about Ehlers-Danlos. A surprising number of the younger individuals I spoke with actually first heard about Ehlers-Danlos from Instagram. And so if you think back to the opening case that I began with, you can see this kind of being the situation for Jess, the daughter, who had not had a clinical diagnosis of EDS, but nonetheless had started to identify with it nonetheless. And this, the support patients find outside of the clinic is really important for them. They not only get medically relevant support, they also find a social network that can replace lost friends, as we've discussed in the previous slides. So friends who understand what symptoms do for your ability to be able to engage in social activities. So instead of being surrounded by people who doubt or are disappointed by patients' limitations, they surround themselves with individuals who understand and can be empathetic. Another thing I want to mention at this stage is what many of my, not many, but a few of the interviewees referred to as a disability. So this is the idea that Ehlers-Danlos is not just a disease that whose goal is to be cured. There is not a cure for Ehlers-Danlos. And so at some stage, many of these individuals come to the point where they have to come to terms with the chronic nature of their symptoms. And for some of these individuals, what that means is to treat it like a disability. So instead of getting upset about their limitations, learning to live with them. And part of this is not just live with those, for themselves to live with the symptoms, but also to get society to acknowledge and accommodate those symptoms as well. And at the very end of the Diagnostic Odyssey, again, borrowing from Campbell's terms, is the Diagnostic Apotheosis. This is not what the end for everyone, because it was the end for all of my interviews, because it was actually an inclusion criterion. Everyone I spoke with, as I mentioned before, has a clinical diagnosis of hEDS. So it's no surprise that this is the pinnacle of these patients' experience. This moment, this apotheosis, leads a patient to greater understanding, and they regain a feeling of control over their life. Campbell refers to this as a return. It allows the patients to integrate wisdom gained on the Odyssey into this world that exists outside of the clinic. It allows them to, well, it doesn't actually allow them. This is actually, I think, a big caveat in addition to the fact that this is an inclusion criterion. But unlike for many heroic quest narratives, there is a real struggle at this stage that persists for patients with hEDS diagnoses to find a balance between the new community identity and prognosis that they have through the hEDS network and the perspectives of non-affected friends, family, and clinicians. So while hEDS can provide significant sense of validation for the patients and can provide validation also for the clinicians they encounter, this isn't always the case, especially for those, as I mentioned, who are not affected. Many of the patients I spoke with feel a continued pressure to explain their symptoms, sometimes even to excuse their symptoms with other individuals who do not take them seriously despite having the diagnosis. So integration is really not without a struggle. Another big caveat is that there is no cure for hEDS. So it's not the case that this simply ends their experience that began with the Diagnostic Odyssey. And then there's also the potential, as I mentioned at the beginning, that once a genetic cause is found, this could potentially change the diagnostic criteria and change how people with current hEDS diagnoses view themselves, both in terms of their identity and their social network. And so that brings us to the end of the Diagnostic Odyssey. And so hopefully we've seen some of the iatrogenic harms that can arise from this long process, oftentimes difficult social interactions entailed in the pursuit of an hEDS diagnosis. I wanted to highlight some of these that we've already talked about and then bring up some other ones that were also experienced by these patients. So as I mentioned, there is the problem of untreated pain, which is, again, the primary symptom that patients complained about in their interviews. If patients have such negative experiences in clinic, some of them do leave biomedicine to seek solutions elsewhere. For those who remain, several of the patients I spoke with did still feel like they were being seen as drug seeking when they complained about their pain to their clinicians. And so these individuals actually explicitly stopped seeking management for their pains, which is obviously a failing in the care of these patients. It is worth noting here, though, of course, that since this pain, a lot of people think that this is centralized pain, and so opioids might not even help. It doesn't mean that there aren't other ways that biomedicine can manage these issues. There is also the problem that we touched on briefly of the lack of education. And so a large percentage of the patients I spoke with had initially seen a number of clinicians, including prominently physical therapists and psychologists, who were not familiar with hEDS as a diagnosis and the limitations it imposes on patients. And so the way that they were managed and counseled actually worsened their symptoms. And finally, there was one case, although I've heard of many others from people I have not yet interviewed, of a mother with two children, both of whom had expected diagnoses of hEDS. So they had similar symptoms, being told that her daughter had Munchausen by proxy and then having DCS called on the family. And so you can think this is clearly a traumatic experience for a mother who's desperately seeking a diagnosis for her children. But it's also very traumatic for these small children to have that kind of an experience and have it linked to the healthcare system. Finally, this is my last slide. I wanted to talk about implications that I think arise from this study for practice. So I really do hope that as we went through these different stages in the Diagnostic Odyssey, that you as audience members did take the time to really try to imagine what your life would be like if you were experiencing these symptoms. And not just today, not just for the next week, not even just for the 4 years to come, but potentially for a lifetime. How that would affect your ability to engage with the healthcare system that can at times be hostile. And nonetheless continue to pursue a diagnosis and hope for an improvement in your health situation. As we saw at the very top of this presentation, these patients are often described behind the scenes by clinicians as difficult. This is an old and out-of-date construct. There's been a push recently to consider not a difficult patient, but a difficult patient encounter. It is not the fault of either the patient or the clinician that these interactions can be stressful for both individuals. This is due, as we've seen, to a lack of clinical training, the psychosocial distress that these patients experience on a day-to-day basis, both in pursuit of a diagnosis and due to the symptoms that they experience chronically. Deficient social support, which we've also seen not only can start that way, but also regularly deteriorates over time because of a lack of general understanding of these symptoms. The limited therapeutic potential of these engagements, which can lessen the patient's resolve to continue pursuing them. And then the high utilization of healthcare services. And again, we saw this as an issue even in the opening case study, where the geneticist was noted immediately that the patient had been seen in clinic numerous times and had had many different surgeries. So it's important to recognize at this stage that the patient really exists in a world, has a permanence in a world outside the clinic. Hopefully this narrative approach to looking at the Diagnostic Odyssey of uncertainty and often heroic scale labor helps to drive that home. And so in holding those things close to our hearts, I hope that this can inform the way that clinicians engage with patients who have comorbid psychiatric conditions, and especially thinking about women and how women's pain is often dismissed by clinicians, but also by society. And so I want to end just by saying that difficulty and complexity do not preclude empathy, nor do they excuse its absence. And I do hope that this ethnographic or narrative approach has provided insight into a holistic perspective on what these patients' experiences look like, and who they are when they come to clinic, with the hope that then this an empathetic view can be taken into things that are sometimes invisible. Thank you.
All right, Colin, thank you so much for that great lecture. Have some comments and questions in the Q&A box here. I just want a couple of our attendees have children that have either been diagnosed or not officially diagnosed yet, and wanted to just thank you for the lecture, that they are very glad that they're here today. So
I'm very happy to have them.
The questions along with that is, why are so one of our attendees has said that their daughter has this but has not been officially diagnosed. Why are doctors reluctant to diagnose? Secondary effects almost exactly identical, dropped out of high school, lost friends, became antisocial.
Yeah, I mean, so one of the things that I hope to do in the next stage of this project is not just to expand the interviews with patients or to do a deeper dive on interviews on particular topics with patients, but also to start talking with clinicians. It's a sad fact that there are actually whole hospital systems that refuse to see patients who have concerns with hEDS. And I think the ostensive reason for that is the incredible complexity of these cases. It really does take a specialist, it seems, to provide robust diagnosis and management for the symptoms. It's also the case, though, that so I gave a talk a couple of years ago on this topic, and I really do think this is something I also want to look into more empirically. Is I do think that for many clinicians, because there's not much that they can do to resolve the issues for the patient, that this can be really frustrating. And I think that's part of it as well. I think that the fact of that kind of inability, the limitations it places on the clinician as well, can be frustrating from the clinician's perspective. And then I think most importantly is the invisibility of these symptoms, and to note that it does affect, that these do affect women, and both the invisibility and the patient population, I think, have real potential for bias.
So next question, we have some viewers that work in maternity at Methodists. So can you elaborate on what pregnancy, both physical and psychologically, might be like for hEDS patients?
That's a great question. I have talked to some women about their experience being pregnant. I don't think that I can speak as broadly to it because the majority of my interviews didn't touch on it, although that would be a really interesting thing to go into more detail about. From the limited perspective I do have at this stage, I know that it can be an incredibly painful experience. One woman I spoke to on her second pregnancy, she had already started, so I didn't count this as a triggering moment for her because she'd already kind of started on the Diagnostic Odyssey, but her symptoms became unbearable with the second pregnancy. I think with hypermobile Ehlers-Danlos, the extreme risks are less from pregnancy, but with other forms of Ehlers-Danlos, it can actually be a fatal condition to become pregnant. So this is another reason that getting referrals, getting diagnosis earlier is really critical, not just because of the stressors that I've discussed primarily in this talk, but because there are real dangerous medical consequences that can arise as well.
Thank you. Next question. I am wondering about the intersection of hEDS and addiction given the pain component. Can you discuss addiction risks?
Yeah, yes, I can. I think I'm not a clinician, so I can't talk about this except kind of like obtusely. I would say that having a really careful view of what the pain symptoms are is important because, like I briefly mentioned, it's very possible that the types of drugs that might be prescribed wouldn't even be useful, even if they were to be prescribed and the patient was to be believed. Of the people I've talked to, only one discussed addiction. The majority of the people who mentioned it in kind of a negative sense, where they were worried about addiction, even though they hadn't experienced it, and that led them to limit the management of their pain through that process. I think it's also very true that there are some of the patients I spoke with had really positive experiences with pain management through therapy, through other forms, through non-pharmacological forms of treatment of pain. But again, it is chronic and it doesn't go away. Everyone constantly mentioned that this is like a limitation of physical therapy, is you have to keep going, even if it works.
All right. How can clinicians reflect on their own biases, especially towards women and Black or African-American women specifically, so that clinicians stop perpetuating these disparities?
I think that's a great question. As a non-clinician, sometimes it's difficult for me to look at these cases and think, how would I approach this without empathy? To me, that seems, again, like this is something I want to look at more closely in the future. I do really just at this point think like a baseline belief that a patient wouldn't be there in your clinic after this long diagnostic odyssey if the patient didn't have real symptoms, you know, and to just start with that belief and then move forward, ask what can I do, I think would be, very important first steps. I also think that it's a very interesting fact that my population, who I drew on across the country, actually the majority of the patients I spoke with are not local, the vast majority, just were all white. And I don't know what to make of that at this stage. I haven't seen statistics about the racial distribution of this diagnosis. And it does also make me wonder, again, anthropology brain turned on, whether this has more to do with how diagnoses are made rather than what criteria are met, if that makes sense.
Sure. So next one is, have you considered covering this topic with those affected by familial ALS and those who have inherited a familial ALS causing gene mutation? I find earlier diagnosis even more important as we are on the brink of pre-symptomatic treatments becoming available.
Yeah, I really appreciate that. I've had a number of, so rare disease is where my heart's at. Ehlers-Danlos is, I think, the rare disease, if you want to call it a rare disease, that's most on my mind at the moment. This is kind of where I see my at least near-term future. But I am very interested in the question of how this can inform more broadly our understandings of similar diseases. And I hope, I really do hope in the future to also expand and look at a variety of other conditions through a similar lens.
So as you were talking a lot about empathy, we just had a question pop up about, do clinicians go through any empathy training? Have there been studies that this helps if they do?
I believe they do. I think this is a moment where I really wish this was more of a seminar setting than a webinar setting. I think in any case, the ways that this is encountered need to be rethought. Our lovely center offers a number of courses in ethics that are available. And I think something along these lines could be really helpful. I really do hope that simply seeing holistically this kind of a broader picture of patient life could lead to this as well. And so one of the things I think is really useful that I don't know what it looks like here at IU, but when I was at Vanderbilt, they did offer courses in narrative medicine. And while I think there are definitely shortcomings to that as a practice, I think the way that it asks clinicians to reflect on the patient as something more than a problem to be solved can be really helpful in terms of building an enduring empathetic attitude towards patients, even in the middle of a very difficult encounter.
Great. Well, that's all the questions looks like for right now. So if you do have questions that were not able to be answered, please feel free to send them to me. It is kmons@iuhealth.org. I'm putting that in the chat box right now. So feel free to reach out to me if you have further questions for Dr. Halverson.
Oh, I also wanted to, it just occurred to me, there is a narrative medicine course and a scholarly concentration here at IU. So a little shout out to that.
Great. Well, thank you so much for joining us today, Dr. Halverson, and we will hopefully see most of you next month in December.
Thank you.
Bye.